first I'm going to figure out how these things work. Good. All right. Good. Well, thank you, Jean-Paul, both for the introduction and for inviting me to be part of this fantastic session. It's, we're in the same group, and yet somehow we don't always know what the other people are doing. So this is a great opportunity. That was beautiful, Pedro. Yeah, really. And Uduna, if you're online, amazing, amazing work. All right. So yes, as mentioned, what I'd like to talk about today is a series of studies looking at the potential role of dopamine in addictions, but also in its many commonly comorbid conditions. Before I get to those data, I'd like to acknowledge some of the many people that helped make these studies possible. That includes a group of terrific trainees, both past and present. And I'd particularly like to mention Isabelle Boileau, Charlotte Caswell, Maya Nikolek, Maisha Iqbal, Sylvia Cox, Natalia Jaworska, Nikki Oseni Kamkar, and Mikhail Malela. The studies have also benefited from terrific faculty colleagues here in Montreal. That includes Alain Daguerre, the retired Bob Peel, sadly recently deceased Chalky Benkelfat, and the very much alive Natalia Castellano-Ryan, Tomasz Paus, and Jean Sagan. These studies, of course, would not be possible without the incredible work done by Jean-Paul, Gassan, and other members of the PET unit in giving us the infrastructure and ability to do these kinds of amazing studies. So thank you. I have no conflicts to acknowledge, to report. All of these studies are funded by CIHR. All right, so just to give you a bit of a background, what we know about the basic features of substance use disorders. First of all, they're incredibly common. Even without counting alcohol or nicotine, the lifetime prevalence is 10% of the population. Not at any one time, but at some point in your life, 10% of the population will meet diagnostic criteria for a substance use disorder. There's no particular reason to exclude alcohol and nicotine problems, and even when we just include alcohol, we're getting close to 30% of the population, again, at some point in their life, will meet diagnostic criteria for a clinically relevant substance use problem. For some individuals, that's just 1 year of partying too much. Their life is a mess, and they manage to get their life back under control afterward. For others, it's decades of serious, serious problems. Both substance use and substance use disorders are more common in men than in women. But that ratio, that differential is getting less and less over the last few decades, and this is presumably driven by cultural changes, cultural norms, rather than a genetic shift in the population. There are also quite marked ethnic cultural differences in who has problems with addiction issues. In both Canada and the US, the highest rates are seen in Indigenous communities. I always get a bit nervous when I say that. I don't want to be propagating stereotypes of Indigenous groups, certain racist ideas about this. But some communities do certainly suffer very high rates of addiction. And overall, we're talking about 45% of people of Indigenous background, again, at some point in their life, will have a substance use disorder. That's a high number, but keep in mind, close to 35% of white European background will, again, at some point in their life, meet criteria for a substance use disorder. So these problems, the differential is not as big as sometimes implied. Also, contrary to what gets depicted in the media, and contrary to who ends up in jail, rates of addictions are not higher in people of African background, Black Canadians, Black Americans, and by some indices, the rates are even lower. Rates are lower again in people of Latin American background, and lowest of all, people of Asian background. Low family income has an even larger effect than culture, ethnic group, and this is particularly true for the duration of the disorders, and this is thought to reflect in large part differential access to treatment and other health facilities. There's also a range in the addiction rates depending on the substance. Relatively low rates of addiction in people who use cannabis frequently. Highest rates with opiates, heroin. In part, this may well be due to the pharmacological properties of the substance. It's easy to imagine that. Although it's probably not just that. I think we can imagine that there's a certain amount of self-selection going on. If you're willing to try heroin, maybe there's some other issues in your life over and above someone who's willing to try smoking a little bit of grass. The most common age of onset for these kinds of problems is during the teenage years and 20s. 2/3 of people with severe addictions had experienced horrific childhood maltreatment. And most people with substance use disorders do not get clinical help. In Canada, substance use is associated with 20% of hospitalizations. That still shocks me every time. I've been quoting that figure for 15 years at least. It still astonishes me every time I have to say that. 20% of hospitalizations, it's extraordinary. And the latest estimates in terms of economic costs alone cost close to $50 billion a year in Canada. There's high comorbidity with other disorders, and I'll talk more about that in a few minutes. And the actual substances that people are using changes over time for various complex social reasons. Over the last 10 to 20 years in Canada, there have been downward trends for youth alcohol and cannabis use, and upward trends among adults for opioids, nicotine vaping, stimulants, and cannabis. In the US, and increasingly so and across much of Canada, heroin is adulterated with synthetic or highly potent synthetic opioids such as fentanyl, but even more potent ones are now out there now, sufficiently so that many people don't even consider heroin strong enough. They will ask for fentanyl. But this is what is aggravating the current wave of the overdose crisis. Fentanyl also ends up in other drugs. People who think they're going to buy a little bit of cocaine, up to 20% of samples now are contaminated with fentanyl. People die of an opiate overdose thinking they've bought some cocaine. All right, so as I mentioned, there's a huge amount of comorbidity. This was first documented clearly 25 years ago by Bob Kruger's group in the US. There are two main clusters. First, there's a cluster we might call the externalizing type disorders. And what here, someone who meets diagnostic criteria for one substance use disorder is at much higher likelihood to meet criteria for another substance use disorder, but as well as any of the other so-called externalizing disorders, impulsive, emotionally volatile personality problems, only some of which are indicated here. It's a bit of a stereotype to say that all people with addictions have an antisocial personality disorder. Some do. But that's really not the most common version of it. There's a second cluster of the so-called internalizing disorders, which is to say people who meet diagnostic criteria for one mood or an anxiety disorder are at much higher likelihood to also have another mood and anxiety disorder. But you'll see that these two large superstructures are also connected in such that people with mood and anxiety disorders are also more likely to have substance use disorders and vice versa. The reasons for this are still being studied, but one implicated factor is the transdiagnostic effects of early life adversity. In this large sample of over 20,000 women, where are we? There we go. Having a history of physical abuse increases the risk, the likelihood of being diagnosed with any of these internalizing disorders. It's not specific to any one particular diagnostic category. It increases risk for all of these disorders. Having a history of emotional abuse increases risk for both the internalizing and the externalizing clusters of problems. Having a history of sexual abuse, the same, increasing the likelihood of both the internalizing and externalizing disorders. Again, there we go. Again, these two large clusters are linked, and these observations have raised the possibility that there might be an overarching P factor, which is to say there may be some features that increase risk for all common psychiatric disorders, not even specific for internalizing versus externalizing. In the latest version of this line of thinking, the so-called high-top model, again, there's an overarching P factor that's thought to influence risk for the whole wide range of commonly comorbid mental health problems. There's then a succession of more specific features that push people more in one direction versus another. And embedded in this type of thinking is this idea that biological parameters that are linked to the higher levels are going to affect susceptibility to a wider range of disorders than features that are linked to more specific symptoms and diagnostic issues. So what might be the relevant biological features? Well, much of my own work is focused on the potential contribution of dopamine. Dopamine, long been implicated in laboratory animal studies, as being important for reward-seeking behaviors. As I'm sure this audience knows, better informed about nuclear medicine and PET technologies than most. 25 years ago, these methods have been adapted to actually measure neurotransmitter release. And so by measuring changes in tracer binding in different parts of the brain under placebo versus drug conditions, we can get an index of neurotransmitter release in different parts of the brain. This paper, published over 20 years ago now, we certainly weren't the first to report evidence that amphetamine increased extracellular dopamine levels in human brain, but it was early enough in that literature that we were able to provide some methodological improvements thanks to collaborators at the Brain Imaging Institute at the Neuro that gave us greater anatomical resolution. And so this study provided some of the clearest evidence that these effects are occurring preferentially within what we would call the ventral limbic subcompartment of the striatum. That aspect of the striatum that, in a functional sense, is what we would call the nucleus accumbens in laboratory rodents, again, long implicated in reward-seeking behaviors. We subsequently went on to find the same effects when people took cocaine in the PET unit. That's another whole long story about how we got permission to do that, but it was an amazing study, and we saw very similar effects following cocaine as compared to amphetamine. We also were able to then see very similar effects following the ingestion of an addictive substance from a quite different pharmacological class, alcohol. Together, these and other studies have provided evidence that addictive substances across pharmacological classes increase extracellular levels of dopamine with preferential effects within the ventral limbic striatum, very similar to as been seen in microdialysis studies conducted in laboratory animals. There are marked individual differences in the magnitude of these effects in people. In that first study that I showed you with the amphetamine challenge, the greater the amphetamine-induced dopamine response, the higher they scored on the personality trait of novelty seeking. This fit very well with what people thought and still think what dopamine is doing. It facilitates reward-seeking behaviors, it facilitates exploration of the environment. So this was an exciting finding. I was pretty happy to be able to report this early in my career. And it gave me a certain amount of fame and a career boost at that period. That said, after this study was published, I started looking at those graphs again, reminded myself, There are only 8 people in this study. It's a pretty small sample. Moreover, the whole idea that a single snapshot of a dopamine system could capture as much as 60% of the variability in something as complex as a human personality trait started to bother me a little bit. It seemed a bit extraordinary that we'd actually managed to do this, and I became less confident that this was a real finding. I was therefore very happy when an American group led by David Zald in Nashville in the US reported a very similar finding, this time using, instead of carbon-11 labeled raclopride, using F18 labeled falopride. This is a higher affinity ligand for dopamine receptors, allowing him to derive a high quality signal from other regions of the brain outside of the striatum where there are fewer receptors. And with this signal, he was then able to plot a three-way interaction. In essence, the lower the D2 receptors within the dopamine cell body region, the midbrain, these are presumably inhibitory autoreceptors, right? So D2 receptors on the dopamine cells that provide self-regulation, inhibitory feedback to the dopamine cell. The lower the number of these inhibitory autoreceptors, the greater the striatal dopamine release, and the higher participants scored on various measures of impulsivity and novelty seeking. With that findings on stronger feet, I then felt interested in pursuing this further, whether we could find out whether this midbrain dopamine autoreceptor signal that affects dopamine cell reactivity was more specifically related to susceptibility to substance use disorders. The next question became, how are we going to define risk for substance use disorders? We had the great opportunity to to study this in a longitudinally followed cohort of youth who've been followed since birth. Actually, it was their pregnant mothers who were first recruited, and then these youth have been followed up ever since then. We have a tremendous amount of information about these young people, and so we were able to then plot models to determine what were the best features that identified risk for substance use problems. Not surprisingly, having a family history of substance use problems was a good predictor of early age of onset of alcohol use and the frequency in which they were using alcohol during their adolescent years. These behaviorally, emotionally volatile and impulsive behavioral traits as young as 6 to 10 years of age also predicted an early onset of alcohol use problems. These same behavioral features at ages 11 to 16, again, even better at predicting who was going to start alcohol use young, how much they were using, also cannabis use. And then sensation seeking, a similar behavioral trait, also a powerful predictor. Of particular importance for this research, much of the variability attributed due to family history was accounted for by the acquisition of these externalizing behavioral traits. Based on that, we then selected participants from the top versus bottom 30% of these externalizing behavioral features and conducted a PET raclopride study in them. 58 participants finished this first study. PET scans were done at age 18, and the two groups were very well matched on age, as well as sex. By definition, the two groups differed on the externalizing traits. They also differed, as you'd expect, even at this young age, in their substance use, with higher already, showing evidence of higher alcohol use problems, more cannabis use, more likely to be a cigarette, tobacco smoker, as well as using other substances. They were also more likely to already have developed at this young age any of a number of different of these commonly comorbid disorders, including the beginnings of mild substance use problems, and differed on various other personality traits that you might expect to see in these populations, primarily related to impulsivity. Our primary interest was the midbrain dopamine autoreceptors, but this study did afford us the opportunity to measure dopamine receptor availability, D2 receptor availability in terminal region areas. And what we found is that the high-risk, high-externalizing participants had elevated dopamine receptors throughout the cortical regions. There was a main affected group, no group by region interaction, so this effect was throughout the entire cortical region. Very similar effects in other parts of the brain, including the amygdala, hippocampus, insula, also all implicated in more complex regulation of reward-seeking behaviors, executive planning, executive control of these behaviors, of planning, and selection of appropriate strategies to get rewards. Within the midbrain itself, contrary to our hypothesis, we did not actually see a group difference, but there were quite compelling correlations across the entire sample, such that low midbrain D2 receptors, again, low inhibitory autoreceptor input to the dopamine receptors, correlated with low sensitivity to punishment and high sensitivity to reward relative to punishment. With these data in place, and given all the information that we had about these individuals, we then decided to try testing a more ambitious hypothesis. What would happen if we brought together all three of these implicated features that have previously been studied by us and others alone as to whether they could predict susceptibility to addictions and their commonly comorbid problems? That includes these externalizing behavioral traits during adolescence, early life adversity, and the midbrain dopamine autoreceptors. In our first study, 52 of those 58 participants had all of the necessary information. As I mentioned, some of them already met criteria for some of these disorders. By age 18, about 25% had met criteria either currently or in the past for any of these different mental health problems. Each of these three features had predictive value, identifying who met diagnostic criteria, not just for addiction, but for any of these different diagnostic categories. When we brought the three factors together, the model was incredibly powerful, 10 to the minus 5, an incredibly powerful model, statistically robust, with accounting for a high degree of area under the curve, high accuracy, high sensitivity and specificity. We then followed these participants up 2 to 3 years later. Additional individuals developed disorders for the first time, and this model continued to be highly robust in predicting who had any one of these mental health problems. I'll tell you, I consider this one of the most exciting findings of my career. It's really quite extraordinary. My only real problem is that it seems too good to be true. The idea that three factors could be so powerful in predicting almost everything in psychiatry, it's a bit hard to swallow. I'll acknowledge, a bit hard to believe. And yet, it's plausible. Let's at least allow that it's plausible. We already know, there's good evidence, that early life adversity, right, it's the prototypical transdiagnostic risk factor for everything in psychiatry. Externalizing behaviors, we know this already in isolation. They're good predictors for the whole range of mental health problems. And dopamine, of course, is also implicated in a whole wide range of mental health problems, behavioral regulation. So it's plausible. That said, I want us to be cautious about that. I'm pleased to say that CHR has provided me money to try to double this sample size, and I hope to be able to say in a couple of years from now that we've reproduced it. In the interim, because I'm not completely patient, I decided to try to pursue this model with a different data set. Here using the Imogen data set primarily from in Europe. It's a multi-center data sample with over 1,000 participants, allowing us to test a proxy of this PET-based model in a much larger sample. In addition to having all of the other behavioral information, there's fMRI data for when participants are engaged in a reward-related task. Some of you might know this task is widely used in neuroimaging studies to measure responses to reward-related cues. In essence, participants learn fairly quickly before they're put into the MRI camera that some symbols that'll come up on the screen are predict that they'll get no reward. Other symbols are indicative that they'll get a low reward. And other symbols will predict that they'll get a high reward. You can then measure brain activations, and this is highly reliable in being able to activate mesocortical limbic regions long implicated in reward-related behaviors. We've had over 1,000 participants with all the data necessary in this study. At age 14, the model was incredibly powerful. We reproduced that PET model first identified with PET, tremendously powerful with the fMRI signal within the substantia nigra, one of the primary dopamine cell bodies in the midbrain. 10 to the minus 25. I mean, yeah, I know, but there it is. Slightly lower accuracy and particularly sensitivity, but still a tremendously powerful model. One of the peculiarities of this imaging data set is that their diagnosis interview did not include substance use disorders. There were questions, though, that allowed us to construct a proxy, and so just as an exploration, we created this proxy diagnosis for substance use disorders, threw them into the model, and you can see still a very powerful, statistically significant model, all three factors continually to predict. It wasn't just in the substantia nigra. Again, at age 14, the fMRI data from age 14, throughout regions of the mesocortical limbic system, combined with the other features, highly significant predictors of who had any of these different commonly comorbid disorders. At age 19, at the age 19 fMRI scan, again, same thing. The reward anticipation responses in various brain regions, parts of this mesocortical limbic system, combined with the other features, highly significant. The lowest for the model as a whole, the lowest or the worst p-value was 10 to the minus 21, right? I mean, just, I'm starting to believe it. Right? Having such a large data set also allowed us to explore how these different factors might be related to each other. In a mediation analysis, childhood trauma affected the likelihood of having a mental health problem through two pathways. There is a direct pathway from childhood trauma directly to having a psychiatric disorder, but there is also an indirect pathway such that childhood trauma increased the expression of the externalizing behaviors, which then in turn increase the likelihood of crossing the threshold to meet a psychiatric disorder. There is also a moderating effect, such that early life adversity interacted with the brain activation responses, and such that the lower the reward anticipation response within the striatum, the bigger the effect of early life adversity. In comparison, people with larger reward anticipation responses were somewhat protected against the effects of early life adversity. This same interaction was also seen in the anterior cingulate. Incredible, right? Okay, so some of you might have noticed that there's a superficial contradiction between the PET and the fMRI data, right? So the PET data, keep in mind, the overall model is basically the same, and so there's a reproduction there. But the PET data is finding that the relevant brain feature is low dopamine receptor inhibition, right? But the fMRI data is finding that it's low mesocortical limbic activation, when we might have predicted the opposite, right? Low dopamine cell inhibition, why not higher mesocortical limbic activation? And I think there are two potential reasons for that. One, keep in mind that the fMRI bold signal is not dopamine specific. It's actually the confluence of all the many different neurotransmitters and neurophysiological processes that are going on within that region. So we can't really expect the fMRI signal to equal dopamine, even though that might be part of contributing to the signal. Second, some of you might know that among the other arguments I've made over the last 20 years, over and over and over again in the literature, is that mesocortical limbic related mental health problems, the expression of those disturbances can actually be either as an increase or as a decrease, depending on what's going on in their environment. In the presence of disease-related stimuli in the environment, there's a hyperreactivity in these mesocortical limbic circuits. In the absence of disease-related stimuli, these systems are actually hypoactive. So based on that, we've pushed this just a little bit further. Here we've tested whether this three-factor model works when we give a disease-specific cue. So here it's an fMRI study. We're giving alcohol cues. It's a block design, so people are shown a picture of some of their favorite alcohol beverages. There's then a tube that goes into the mouth, gives them a 1 millimeter spray. This is not pharmacologically active, but they can tell the difference. They can taste that this is alcohol. It's their favorite alcohol beverage sprayed into their mouth. They're then told to swallow it and then spend another 12 seconds looking at pictures. This is then compared to the effects of looking at pictures and getting a spray of their favorite juice into their mouth. And then we contrast the brain activation responses to the alcohol versus juice cues. Okay. Here we find that this three-factor model again is working. The overall model is statistically significant. And alcohol versus juice cue response is predicting problem drinking 7 years later. 7 years later when we followed up these participants, right? Whoops. There's a highlighted p-value. All three of these factors were contributing to the model. CTQ, the childhood adversity measure in this particular case, not statistically significant by itself. And yet when we compare a two-factor model without early life adversity to a three-factor model with it, the three-factor model is significantly stronger than the two-factor model, indicating that in some way early life adversity is contributing to the strength of these effects. In this case, I want to reemphasize again that when we're using this disease-specific cue, it's a bigger brain activation response, and it's predicting specifically who's developing alcohol use problems. It's not predicting the whole range of comorbid disorders. So we now have a disease-specific model. Again, the effect is not specific to just one brain region. The model works when we're putting in activations in other parts of the brain, including the ventral striatum, the ventromedial prefrontal cortex, and the cingulate cortex. All right, so in summary, what do all of these studies tell us so far? First, we have evidence that young adults at risk for substance use disorders have altered mesocortical limbic dopamine function. Second, the PET and fMRI-based models are strikingly powerful, although I think this audience in particular might find it interesting that the PET model shows evidence of higher sensitivity especially. Now, this might just be a spurious and lucky finding due to the small sample, but it also raises the intriguing possibility that this neurotransmitter-specific information is actually getting closer to the relevant disease process than the less specific fMRI signal. Irrespective, the combination of altered mesocortical limbic pathway regulation as early as age 14 combined with high early adversity and high externalizing behaviors, is predicting a wide range of commonly comorbid mental health problems. Low versus high mesocortical limbic activations to monetary versus alcohol cues is predicting multiple disorders versus alcohol problems specifically. Together, these studies seem to be identifying a novel multi-level diathesis stress model from transdiagnostic factors through to precision psychiatry. Together, these findings have, I will immodestly propose, profound implications for our understandings of nosology, etiology, and targets for early interventions. Thank you very much.